Again, I'm Kelly McCutcheon. I want to welcome everyone to the Georgia Legislative Policy Forum. We're getting into the meat of our schedule. This morning, we're going to be focusing on healthcare with two panels. And this is our first panel, which is focused on employers. A lot of people don't realize, after government, large employers pay for most of the healthcare bills in our country. And it looks like insurance, but it's really not traditional insurance. It's really self-insured companies where they're actually writing the checks. And usually employers are fairly passive. They hire a TPA, a third-party administrator, to handle all the healthcare stuff. But every once in a while, there are employers that take an active role because you're tired of paying the 10 and 20% increases like all of us are frustrated with our premiums going up. This group has had incredible success with that. I'm proud of them because they're Georgia employers, and I think they can sort of lead the way in understanding these best practices that we can try to replicate in healthcare reform in other areas of Georgia. The group is called EmployersLikeMe. I've been following them for many years. The amazing, innovative
Test one, test two.
But recently got a chance to attend their conference down in Savannah about a month ago. And not only just amazed with the ideas they've had, but the collaboration. They sit around and just share, this worked, this didn't work, and they're constantly iterating and looking for solutions. So I thought it'd be really helpful for us as other employers can learn from them, but also the state of Georgia. The state of Georgia operates one of the largest employer plans in the country. 650,000 covered lives, $3.4 billion spent every year. That's a lot of money. And maybe there can be a public-private partnership to learn from what of our good Georgia employers are doing. The moderator is Don Betts. Don works with Georgia Tech, and keeping up with our theme of rural Georgia, he's from Douglas, Georgia, and he has been working in sort of coordinating the employers like me for many years, doing a fantastic job. Don is the perfect person to coordinate this group. He has lots of knowledge in many different areas, is a great collaborator, and we're thrilled to have him and his colleagues here today. So please welcome Don Betts.
So I don't know about y'all, but the main takeaway so far is we've got to be careful. We cannot let policymakers and politicians from Illinois migrate to Georgia. Boy, that was interesting. I'd love to have him at my Thanksgiving table. It would be fun. You could probably get out alive. So, as Kelly said, I get the distinct pleasure of being able to staff this group of Georgia employers. And we have about 185 folks in our network. We've been rather low-key. It's a trusted kind of colleague-to-colleague type peer-to-peer learning network. And we really try to get together and share ideas, just as Kelly mentioned with our summit that we recently had in Savannah. Now, why are we doing this? There are all kinds of other organizations around health, and many that the employers are involved with. But what we find is that often the employers are outnumbered at any health meeting you go to. As policymakers bring together folks to talk about healthcare policy, they oftentimes forget about one of the biggest customers and really the biggest avenue to get to the other customers, and that are the employers. So we are together to work on that. The other way to look at this is think about if you were running your business and you had one of your main components of that business going up 10 to 20% every year. What would you do? Well, you know what you would do. You'd wrestle that thing down to the ground, you'd work your supply chain really hard, and you'd figure out how to cut that down and to get the best service possible. Well, that's what they're tasked with in the healthcare world. But unfortunately, what we find is that they're asked to do that with one hand tied behind their back because of some issues that we'll bring up this morning. So it's a very challenging world that they operate in. And I think it's something, if you don't take anything else away from what we talk about this morning, is that when you're thinking about legislative policy or just rules, regulations, procedures around health care, make sure that employers are at the table. Make sure some customers are there that can talk about it. My father a long time ago told me, said, son, the people that are doing something aren't going to change it. And, that's a real lesson I think that still holds true. And these employers have been able to come up with some very innovative practices. At first, I thought when I got involved with these folks, it would all be about price and cost. They quickly taught me that's not the case. It's about access to care, quality care, and then cost. And they've taught me that usually the best care is not the cheapest care. So it's not a group where we talk only about cost, it's how they can take care of their employees and be productive and have good, healthy cultures in their workforce. So with that, what I'd like to do is we have three great folks here, and you can see, of course, and I'm going to kind of do a quick introduction. Lisa Evans with Southwire, who's the Director of Living Well. Now that's a pretty cool title. You'll have to dig into that a little bit with her. And then Barbara Barrett, who's the Director of Benefits for Langdale Industries down in Valdosta. And then last but certainly not least, Kim Johns with Mohawk Industries, who's the Director of Employee Benefits. And I've had the pleasure of working with these three ladies for quite a while, and it's truly an honor to be with them and to have them here this morning. So what I'm going to do is ask each one of them to take about 5 or 10 minutes and tell us a little bit about some of their biggest challenges that they have and what they're doing. But then we want to leave a lot of time for some interaction and some questions with you. So be thinking about, here's your chance to talk to some of the folks that are in the trenches, that are really having to work through some of these issues and to make the healthcare system work for their company and for their employees. So it's a great opportunity for that dialogue. So without any further ado, Lisa, why don't you get us started?
Okay, thank you. Good morning. Wanted to share with you a little bit about Southwire, just in case you may not be familiar with us. We're in Carrollton, Georgia, which my joke earlier was head toward Alabama, then turn left, and just go for a while. Just when you think you're lost, you're almost there. But we're a private company. We're a $5 billion company. The shareholders of our company are the children and grandchildren of Gen 1, Gen 2, as we like to call them, of our founder. And one of the privileges that we have is being able to talk to them and communicate and hear back from them. And many of the wonderful things, and I've worked for public companies and I work for private companies, is do not be deceived by the fact that we're private. That does not mean that we're not watching what we're doing and being very, very efficient in the way we do it and the way we grow. As I mentioned, we're a $5 billion company. Our goal is to double that in the next 10 years. So, unfortunately, the way it looks, that won't happen from what's going on here in Georgia. But next. Let me tell you just a little bit about Southwire. We're actually the largest wire and cable manufacturer in the U.S. When you look at how we compete internationally, I think we're tied for third, although I think one of them's up for sale, and we're the only one that's here in the U.S. So that's very important to us, as well as our shareholders. We have about 7,500 employees, the majority of them here in the U.S. We do have some facilities in other locations, but for the most part, we're U.S. driven. We have 32 wire and cable plants throughout the U.S., 10 customer service centers, which is where we cut and draw wire at different lengths and distribution more than anything else. Right now, we've gone from 11 groups to 2 groups to 5 groups. We have 2 groups now. So it's all about one Southwire getting back to our roots. It relates to the construction system, and then it relates to the power systems. And as mentioned earlier, we are global. If you were to guess how much we're going to spend next year on healthcare, and that's just here in the U.S., I would dare to ask you to guess, but you will gasp when I tell you what that is. $91 million. That is what we're going to spend. That is a budget. That is responsibility that within HR that we have to manage. So it's something that we take very seriously. Our employees, for the most part, are hourly employees, rank and file, as we like to call them. They're standing on their feet 12 hours a day in conditions that are not heated or air conditioned, and they're working 24/7. Our average tenure, I have someone that works with me who's been there for 43 years. I've been there for about coming up on 11, and I'm still a newbie by all stretch of one's imagination. But 91 million, when you start looking at how that's going to be spent, 60% of that is directly paid by Southwire through the claims and other expenses that we have. 20% of that employees will pay in premiums. As you well know, premiums are what you have to pay to be at the table in order to have the coverage. And then you've got another 20% laid on top of that that relates to those that use the services, what they're paying in their what we call out-of-pocket cost. So, and those are obviously, you don't always know what you're going to have. Not the same people, the same amount every year, but that's kind of the split of how it works. So you can see the economic impact of this, not only on Southwire, but our employees. And at Southwire, the reflection of who we are is our employees. And as I mentioned earlier, I'm very blessed that our shareholders view our employees as being very, very, very important. They are the community. They are the people that make us who we are. We currently, probably just a couple of things that you may want to know. In Carrollton, we have an on-site medical center and pharmacy that we've had for over 20 years. It is a primary medical clinic, not workers' comp or occupational health. It is strictly primary medical care. I have 5 mid-level or MD providers there. Our clinic is certified and as a primary medical home, although that companies are we're moving away from that kind of just thought. But we also have a physical therapist on site, digital x-rays, mammographies, and a lab. Next door to that, or built into the same building, is our pharmacy. And probably the 10 years I've been there, we've had 5 different companies own our medical center or pharmacy. But if you ask those people who they work for, they'll tell you Southwire. We may not write their check, but they are committed to understanding and helping us as we navigate through a system. We've really done a lot of changes over time. There was a time where pharmacy was the goose that laid the golden egg, so to speak. In relationship, if you could find a way to buy pharmacy drugs directly and get any kind of discount, you really had to be stupid not to be able to make that work. Well, those times are far, far behind us. And probably looking at a system of care, I cannot imagine, because I can't duplicate, I don't have enough employees everywhere to duplicate an on-site medical center and pharmacy, but having that gives us an edge, and it helps us better understand, but it by no means is something that makes everything okay. It just means it's a different system of care. And probably the biggest change that we've made over the last 4, 5, or 6 years has been around pharmacy. And it's been something that, while isn't the big dog of all that 91 million, it is the largest and fastest growing component of it. And it doesn't take many people to move that needle when you think about specialty medications. So we probably 4 or 5 years ago, we started contracting with Walmart. We did direct-to-employer pricing. Caterpillar had just done it. So we kind of I had some resources there, chatted with them. So for people in Carrollton, use our on-site pharmacy. Everywhere else, we ask you to use Walmart. And oh, by the way, if you don't, it costs you a little more. And often I tell employees, if you go use another pharmacy, I can't make it cheaper because they don't give me the deal that Walmart or my on-site gives me. I can't give you what I don't have. So it has been quite effective, but it's been effective in different ways over time. Right now, we've moved all of our specialty medications as far as distribution through our on-site medical center. And the reason we did that is we started looking at coupons, for instance. You know, some of these drugs are $20,000, $30,000 a month. or dose. So we started seeing manufacturers' coupons out there that were $6,000, $7,000, $10,000 for one bill. But the employees were the only one that were able to access that. Well, we don't have a big copay on specialty. We don't want to make it so you can't get your medication and what's going on. But we started working with our on-site to use those coupons so that we all benefit from it. Our employees, pretty much it covers their copay, but we're able to get that particular component, those dollars back. Now, one of the things I'll tell you is that within the first 6 months, we had saved $200,000. And that is saved, and I use the word saved because that's a very deceitful word. It's bending trend most of the time, making it not as bad, but we literally took $200,000 out of our cost. Employees didn't get it, Southwire didn't get it. We got it back from manufacturers, and that felt good. So there's not many of those situations that occur. It's a very complex system, pharmacy, but I will tell you that system of care is one of the most important things, intuitively knowing how to use it and having it there, but we have to measure and we need data. Those are things that are quite lacking in our system. So. Barbara.
Well, I'm Barbara Barrett. I'm with the Langdale Company. We're located in South Georgia in Valdosta. Been in business since 1894 and going strong. We have 23 different companies that fall under our corporate umbrella, and we're extremely diversified. We range from manufacturing, we manufacture oriented strand board, medium density fiberboard, molding. We have car dealerships. We have a golf course that was developed by Davis Love. We have a development around the golf course. We have hotel, banks. So we're extremely diversified, so we've got a wide range of employee type. About 60% of our employees are manufacturing employees, blue collar. We have 1,300 employees. Our demographics are, the average age is 43, so we definitely have an aging workforce. 84% of our workforce are males. We've been self-administered with our health plan since 2000. And what that means is we opened a business, our own TPA. The employees there are our employees. We pay our own health and dental claims, which gives us access to our data. And data is critical, and I think that's something you're going to hear from all three of us, is access to data is extremely important. Prior to 2000, we were with a third-party administrator, and we had a good bit of difficulty getting information about where our cost problems were, our issues within our health plan, and our costs were going up exponentially. And at that point, our owners decided that we would become self-administered. And since then, we've got all of our data now since 2000. And we've done a lot as far as drilling down with our data, developing programs, identifying cost issues. For example, we have a database where we put all of our medical claims, our dental claims, health risk assessment data, biometric data. Our medical management information is in there. It's all in one database. So if there's a concern or an issue with the patient, we've got access to anything that is going on with that patient where we can help and direct their care. We do direct contracting with providers. We have some pretty good contracts with, for example, Mayo Clinic, Houston Clinic, and we direct the employees to those facilities. We have a health advocate that works with our employees, meets with them face-to-face, at the employers and during work hours, working with them on their disease management issues, any type of health issue. The health advocate will actually go to the doctor with the patient if the patient asks them to try to help them navigate the health system. Our focus has always been to try to educate our employees and help them be better consumers. We have one health plan. It's just a PPO plan. We've looked at consumer-driven plans, but because our population is so blue-collar, we've thrown some things out there, and it just really hasn't worked. So we've stuck with the PPO plan. We identified through our data in 2014 that we had a large population of diabetics that were not adherent to their medication. And as a matter of fact, we had 3% that were adherent to medication. So what we were seeing was increased ER visits and increased hospitalizations. So we partnered with a local independent pharmacist. We did just the opposite of what Lisa does. We focus on the independent pharmacists in the area and partner with them. And we actually steer our folks away from the big boxes to fill pharmacy. And the pharmacist staffed up a little bit, and his pharmacists work with our diabetics. We implemented a diabetic program that had an educational component. We provided them with the glucometers, and they have to check their blood sugar 3 times a day. All of that is done through Bluetooth and is downloaded to the pharmacist. The pharmacist checked their medication, combined all their meds. They had to get all their meds filled with that pharmacist. And what we discovered was that we had about 2% of our diabetics that were taking medications that were contraindicated to be taken together. In fact, could be fatal. And the pharmacist reached out to the physicians and got that corrected. But now, we just did an analysis on those diabetics, and they're now 97% adherent to medication. What we did was we dropped the copay for the meds to a $5 copay, not only for their diabetic medications, but also for any comorbidities that they had as well. And so we saw an increase in pharmacy, but we saw a correlating decrease in ER visits and hospitalizations in that population as well. So we now have 90% compliance. We've got a lot of good feedback from those patients, and it's been a good program. That pharmacist also does our 90-day fill at retail. We eliminated mail order out of our pharmacy plan. We got a little bit tired of trying to deal with the games that get played with mail order pharmacy and the spread pricing. So we brought it local, and that's worked out well as well. We developed through working with our data, we developed a partnership with a sleep apnea program, and we have our folks tested for apnea if they meet certain criteria. We have seen a definite decrease in that population with apnea, not only with the comorbidities they have, like hypertension and cholesterol and diabetes, but we've seen a decrease in the medical spend in that population as well. Let's see, we do reference-based pricing. We have a reference-based pricing model for hospitals. We work with a company that audits hospitals, and we pay according to the audit. Sometimes hospitals aren't real happy with that, but it's been beneficial to the plan. We're also looking into telemedicine. We've got some facilities that are in a very remote area over in Willacoochee, or Hoochie Coochie as some of the employees call it. And there's no access to care over there without driving at least 30 miles. And so we're working with one of the hospitals in that area to put a kiosk in at the Willacoochee facility and access some of the physicians who are based with the hospital to provide telemedicine, not only to the employees, but to their dependents as well. And what that'll do is that population of employees are among some of our sicker people because it's mostly men. They won't take off work to go to the doctor, and they won't take off work to go get their meds. So we're going to basically just bring the service to them at the facility. It's kind of like what Lisa does, just not to the degree that she does it with her clinic. Am I finished?
Are you?
Well, you're looking at me. I figured I was out of time.
Yeah, just another minute or two.
Okay. We have a wellness program like everybody does, and that includes a reduced copay for medications if you participate in the wellness program and the DM program, and reduced cost for gym memberships. Tobacco cessation, I think that's pretty much what most companies do. We pay that at 100%. But if we looked at our wellness and disease management programs that we've got in place, and we had a 6.8 to 1 ROI, which estimated to a $2.7 million savings. Our medical spend in our health plan is right at $9 million, not 91, $9 million a year. So we've got a much smaller population than Lisa.
Right. Thank you, Barbara. Kim?
Hey, hello. So we're Mohawk Industries. We are your largest flooring company. So feel free to see me if you need carpet, tile, rugs, hardwood, laminate. I can get you set up. So Mohawk is global, and if you know anything about Mohawk's really grown by acquisitions over the years. Our corporate office actually is in Calhoun. So you get up 75 and drive 60 miles, and there you are, in the middle of carpet capital. So you can see Mohawk is a global organization, but our biggest footprint really is in Northwest Georgia because that's where it all came together. So we do have a strong mission around sustainability. We are one of the largest recyclers of plastic bottles, like what Barbara has right there that goes into carpet products. And we've also taken that sustainability kind of approach with our healthcare plan. And so I think what's important to know, I think for all of us, while it's different, there are common themes, and it also is a journey. Today, when people want a quick fix and you're worried about this year's budget and next year's budget, you also have to remember where you've been and where you ultimately want to get to, because it does take a minute. So for Mohawk, our strategy takes some of these parts. We've been very lucky, and we're proud of the fact that we've had about a 2% trend year over year since 2009. And one of our biggest focuses is not only on what the company spends, but what the employee spends, because we have to make sure that our healthcare is affordable for our employees and their families. So when we look at it, our primary focus, our vision has really been to have the healthiest and safest workforce in industry. And so not the carpet industry, not manufacturing, just in industry. And everything we do ties back to, are we driving that initiative? And so as we go back and we look at where we've been, where we are, and where we expect to go, you can see by our footprint in Northwest Georgia, half of our population in the U.S. really reside from Cartersville through Dalton, with some smattering in Chattanooga. So we really have the ability with that 7,500 employee count to be able to do something. And so for us, that equates to about 15,000 members. So what we do in Northwest Georgia has really started to cascade across the rest of the country. So what is that? So similarly to Lisa and Barbara, we've put on-site clinics. So we don't have one, we have about 24. They're all embedded in our plants. So the convenience factor, we believe, is one of the biggest differences. We do allow employees to go during their work schedule, which has not always been an easy path to navigate with plant managers who have, the mission in life to get the work done. But if it's not easy and it's not convenient, to your comment, right, people are just less resistant to go. They don't make the time. We have, like I said, about 24 on-site clinics. They are managed and staffed by Cigna, who is our partner. And so they have evolved a great deal in the last 8 years. They are staffed by mid-levels, oversight by a physician. There is not a pharmacy connected with this team. We use a traditional PBM, but we do have some fairly aggressive plan design components that we had to deploy after 2014, when specialty pharmacy spend was like 48%. So that was an interesting time, but we have that under control at this point. So we're not too worried about pharmacy. We do provide preventative services, diabetic supplies, all that kind of good stuff at no cost to the member. So we don't want to hear that cost is an impediment to being compliant, which is a huge initiative for us. So Mohawk has adopted a high deductible plan. We've had that since 2012. We like to say we have one choice, and that's our health plan. You can choose to participate or not. So the good news is most people do. We have about 80% participation. We've always had about 80% of our employees participate in the health plan, back from when it was a PPO through, I think in the summer when we pulled the most recent participation numbers. So in our clinics, we drive a lot of activity. They've been a traditional kind of come in, treat the symptom, go back to work, go back home, wherever it is. Now we are really trying to deploy a model of a care team. So Mohawk has a philosophy that you have to get your biometrics. We do it every 2 years. And we encourage you to do that, you and your spouse. You can certainly choose not to, but it does cost you more to make that choice. So we have about 97% participation of our employees that get their biometrics and their spouses. And then that really drives the outreach from the clinic team so that we can actively engage you as the employer or the spouse to end up in a better health spot. Because if we can get you better educated, if we can get you pharmacy compliant, if we can help you manage and understand what's going on, you are going to spend less. Certainly Mohawk hopes to spend less, but from an employee out-of-pocket perspective, that's significant. So part of how all that is done, to Barbara's point, is about data. So we have wrestled with this issue, I think like every other employer, right? We're not unique. But how you get it, what you do with it, what's your responsibility, how you balance HIPAA, how you balance trying to get to the employee who really doesn't get it, right? They're not interested. They've always felt this way. This is how their parents were. It runs in their family. It's just a fact of life. And to try to be impactful to that really can change somebody's, literally their life. And so that's really part of our big driver. Everything we do goes to this vision, but really our ultimate objective is we want every employee to be self-managed. We want them to understand where they are and understand what they need to do and then do it. So for us, it really comes down to that. So some of the other things we're doing as we've moved along our clinics to become what we call a care team. So we want to surround those people who need the most help with the most services. We want to put it in your way. We want to make it hard for you to say, no, thank you. So we spend a lot of time and effort. We have an extensive team through Cigna of coaches, providers, care advocates, case managers, I'm leaving out, referral coordinators. So this is all accessible for the member, and it can be steered through the clinic. It can be steered through your local local physician. And as we look into 15, 16, 17, and 18 then, we really became strong believers that this whole notion of care coordination, right, it's not unique. We didn't think it up. But how it gets deployed and how people know how to navigate, because let's face it, most people have no experience in how to navigate through the healthcare system until they're in the middle of it, and then it's emotional, it's expensive, it involves themselves or a family member, so a great big swirl starts. So as we look to evolve and what we can do through our clinics and now these care teams, and we want to get it everywhere. So part of how we're doing it specifically in Northwest Georgia, we worked with our Cigna as our partner. They weren't able to really build the system that we wanted, so we've done it ourselves. So we steered through plan design for the last 3 years, from 15 to 17, 1/1/18. The approach Mohawk is taking in Northwest Georgia from about Cartersville through Chattanooga is we're building our own custom network, which we swore we'd never do, but here we are. And so we are not owners of the contracts. We did hire a network partner to do that. But the most important thing is we are asking all of the providers that are in the network to clinically connect their data. So we want to know and have the clinic team and your physician know everything about you. So that experience when you go in and your physician says, so what medications are you taking? And you're like, well, I'm not sure. I think I'm taking this, and they don't have your list, and you forget. And all of a sudden they don't have the full picture. And so part of our objective is in this clinically integrated delivery system, we want the physician to know everything they can know about you so they can manage you holistically and then help drive this care coordination path, right? Everybody knows the PT story. You go for surgery, you have surgery, you go for 2 PT visits, it's too expensive, you quit going, you think you can do it at home, and now you've got a whole nother set of issues later on. So we're also trying to deploy bundled payments to hold everybody accountable, the employee and the provider, to seek that full continuum of care. So I don't know if I'm out of time.
Right.
Okay, so I think for us, this custom network, and I probably shouldn't make a commercial, but I will. So the intent of Mohawk building this network is not that it's just for Mohawk. Our intent really for it to be sustainable in Northwest Georgia is we need other employers to join in so that we can really try to be impactful to the overall experience for the folks who live in this area. And so, plan design, what you resource will be custom to the different employers, but we know we need them if we're going to really make this a viable entity. So for us, that's what we're driving towards.
So we've left a good bit of time here for questions, and so I want you to think about those. I heard something that I want you to comment on again, any of you here. Data. We talk about data, and if I go to an insurance company and say, well, what's the deal with data? It's available. We give it to any company that asks for it. So something that must not be exactly right, because Barbara, y'all actually went to the cost of, paying your own claims so that you could have your data, and you gave us some very good examples with the diabetes program and other things where you mine that data and determine what programs you needed. So the other two of you, how easy is it for you to get actionable data in a timely manner on your health claims and all of the other integrated health concerns?
I can tell you from a standpoint of Southwire, you would think having 7,500 employees, which is about over 14,000 belly buttons, as I affectionately call them. When it comes to getting my data, it is like pulling teeth to try to negotiate with a healthcare system. We're with Anthem, which is, the big gorilla. They give you good deals on the cost, but it's a very old and not a very user-friendly system when you want to know something immediately or in real time. But what we've been able to do is with our on-site medical center, we're actually piloting with one of many sites, EPIC, which is EMR, electronic medical record. But it's not just a record your doctor uses, it actually has a portal where the employee can interact. And it has telemedicine. So that is becoming, or video, let's just call it that. You start calling things telemedicine, then it becomes a legal issue, and legislatively we have to understand all those things. But for us, if we hadn't built it, it's not there.
So you essentially had to go create a fix for the fact that you could not get integrated data.
Correct, and we still don't have one yet.
Okay, and Kim, you're doing the same thing with your medical neighborhood, correct?
So we are. So we work very heavily. So on the Mohawk side, right, we work with de-identified data. Mm-hmm. And it is very difficult to get, but we get very specific information, de-identified, but we take action on that and then we send it to the partner and say, are you working with these people? And the conversations that have evolved in the last 4 years so first of all, it's part reaction time to data, right? Because it's at least 60 days late if things work perfectly. And so trying to change that continuum that when you get discharged, you need to call somebody today. Those are just constant conversations and figuring out who can drive that within the partner's organization, I think.
There's also, I mentioned telehealth. That's one of the things I think that we enjoy the most at Employers Like Me is being able to put together pilot programs to try to test these ideas. And for instance, Barbara's company was involved in a telehealth pilot that we did that was directed by the Department of Public Health, who we partner with very closely. Also, Emory University was involved with that, and one other of our employers in the Valdosta area. And it was really pretty neat because people there at the local level could go in, get a skin cancer screening, and immediately they were talking to one of the world-class dermatologists at Emory University. And they were able to quickly let them know, yes, you need to go see a local dermatologist for that immediately, or no, that looks like that's fine, just keep an eye on it. Any comment about that, Barbara?
Yeah, that was a great project. We had I think it was 42%. There were only 27 people at Langdale were screened, and I think 22 at the other company that participated. But 42% of our folks that were screened were sent on for further testing with a local dermatologist. And we'd worked out an arrangement with them where the employees could get in immediately and be seen. And out of that 42%, 35% actually had cancer, a type of skin cancer. And so they were treated immediately. And I asked them if they would have gone to the dermatologist about that spot, and they said no, they probably wouldn't have thought about it. They just decided because it was free and it was during work hours and they could talk to a doctor, they'd participate in the project. So it was very good. I look forward to other projects with public health.
Well, there's a lot of opportunity there to collaborate and work on these issues. You know, one of the things I think that you need to take away also from this discussion is not just the fact that the employers are within their own walls working on these issues. You heard several instances here where they're actually trying to impact the whole health of the community. And in fact, we also help staff some local roundtables in the rural areas. And what happens there is typically the discussion goes from sharing challenges that they're having among the employers to very quickly, hey, we're all hiring from the same, unhealthy pool of folks. How can we genuinely, change the culture of health in our community? And many of us are from the fried chicken buffet line, and it's hard. And so there are a lot of challenges, but we actually have some interesting and good examples where, just think about this. In many of our rural communities, and even in the Atlanta area, who are the true leaders oftentimes that make things happen? It's the large businesses and the employers and those families that have been there and invested and really have some vision for their area. So it's quite natural that these employers would be the one to lead the charge to improve healthcare and to improve that culture of healthcare in their local community. And what we've discovered is they're very willing to do that. They're excited to see that other folks are interested in making that change, and they'll be glad to help. One other quick comment about on-site clinics. Many people get kind of wrapped around the axle and they say, oh my God, I got to have this huge separate building and a huge pharmacy and da-da-da-da-da-da. No, we've cataloged over 70 on-site clinics and businesses around Georgia, and that's not even really touching the Atlanta market. And what we found is they're all shapes, flavors, and sizes. From just a local PA from the local hospital coming over for a couple hours a day to a full-blown clinic. You go to Kia and you see an ambulance sitting there. It's kind of like, wow. So that's the other extreme. I had a funny story. I was in Savannah talking to a benefits director, and I asked him, he had an on-site clinic, and I said, how long have you had this on-site clinic? And he thought for a minute, and so finally he goes, well, I think, Don, don't hold me to this, but I think it was about 1868. And I went, what? And he goes, yeah, we own our own little island off the coast of Savannah, and we had a family doctor that was right there. He lived right there, right next to you, right next to the mill, right next to the facility. And when anybody was sick, we went to see that family doctor. And so I thought, my gosh, here we are kind of coming back around to what we knew worked a long time ago. So if they could turn the lights down just a little bit, I would love to have some questions that we could ask the panel here. Any comments or questions? Yes, sir. And they'll bring a mic to you, I hope, so we can all hear it.
Yeah, thanks. It's very intriguing. I know data it seems like healthcare has got lots of data, but very little actionable data. It's kind of sad. You mentioned actually, I think Barbara talking about finding out that patients were not taking their medicine for diabetes, but that wouldn't be on like one of the coded claims that you would get out of insurance companies. So how did y'all get that data, and did you have any problems with HIPAA and getting your employees having to sign a bunch of permission in order to get sort of that level of data?
Well, our TPA, we're HIPAA compliant.
1, 2, 3.
From beginning to the end, we're HIPAA compliant. And so we have access to the data. I manage that company. And so we've also got our pharmacy, and it wasn't difficult to drill down with the pharmacy and determine that people weren't refilling.
Okay, so you got from the refilling, you went from the doctor's orders, which you had because you ran the clinic, right?
Well, they had a fill, they had
Okay.
a diagnosis.
Okay.
So if they had an initial fill and they had a diagnosis of diabetes and then they didn't have any other fills, we put them on the list.
Gotcha.
If they came back later and said, look, I'm managing it through how I eat, and I really don't need to be in the program, then we verified that, and if they didn't want to participate, it was an opt-out program. Everyone was put into the program, and they could opt out. But we had a couple that said they were managing it via how they ate and diet, and so they opted out. But we have access to all of our data because we are HIPAA compliant.
Okay, thanks.
I think we had another one right here.
Let me preface this with saying that I am a pharmacist amongst my other things that I do. And I have been involved in MTM. It's called Medication Therapy Management, and that's really actually what you're talking about. And I've advocated for that a long time because it does increase patient outcomes and decrease cost, even though your pharmacy spend may go up. I really commend you for what you're doing. One of the things that I have seen, actually, I've got two questions. One of the things I've seen is the concern for patient privacy, and that they are very willing to talk about even very private matters, but they're not big on this going back to the insurance company. And I wanted to really hone down on this patient privacy. And as you are getting all of this data, how are you protecting that? You may have a lot of diabetic patients or COPD or CHF, but there may be only a handful that have MS, that are cancer that of a particular type that are going to be identifiable. I want to see how you're protecting that. How are you dealing with prescriptions for the unmentionables, that they may want to go to a self-pay physician and self-pay, but those are the drugs that are going to cause the interactions. I have seen in practice adult ADD, sexually transmitted disease, the alcoholic that goes on abuse. They do not want that shared. So that's one. The other one is a big problem that I've seen is on hospital discharges. And you've got a problem with readmissions within that 30-day period. And what I have seen is that there is too great a continuous refill by the pharmacy, and there's no stop order on those drugs. So what you get from your hospital discharge is not consistent with what they're already getting. How are you dealing with that?
I can comment a little bit on those because they're very close to my heart. I'll start with the last one because I can remember the last thing you said, but I made a note on the other. So hospital follow-up. In Carrollton, we have one hospital system, so it's not hard. You know, you're either there or you're not. But our on-site pharmacy, and let me maybe say this first, the medical center and pharmacy, while it is on our property and we do see employees and their dependents, we have no access to that information individually. We've been there for over 20 years. I have a feeling if we'd have done it poorly, nobody would be going there. We do it to the point where our phone system, we don't even use the same server as ours. We do not want there to be any question that as a company, we know this information. We even went so far as to how we set up access. We originally were going to have it built where you come through one doorway, you can go here for fitness and here for this. And we said, no. some people, we were doing GED at that particular time many years ago, so nobody wanted to tell everybody they didn't have a diploma. So we created independent entrances that are very unique. We have our pharmacist, I have a full-time pharmacist at the clinic. It's owned by Walgreens at this time, that all of her job is following up with patients and meeting with patients. We actually have a room off of our lobby where she meets with all of them. Our adherence rates are much, much higher than the state of Georgia as a rule. It's not rocket science, it's just trust and compassion and understanding what's going on. We also do bedside fills. If you're in the hospital and you need medication, our pharmacists will stop what they're doing, get in their car, and ride to where you are and make sure that you get the medications. But I do think privacy is a big deal. I personally would not like all of my stuff, whatever that is, getting everywhere. But you would be surprised how many employees walk in my office and just tell me everything. And I'm like, oh my.
More than you ever wanted
When did
to
you
know.
ever wanted to know? The reason they have to do that is because nobody else is listening. There isn't any other way. But I do think pharmacists are underutilized. They are doctors.
Oh, yeah.
Counting pills is not what their expertise should be.
So one of our key partnerships that we've developed this last year has been with the Georgia Pharmacy Association and a group of independent pharmacists. We've got a question over here, Senator Kirkpatrick.
Yeah, I wanted to congratulate you all on what you're doing, the hard work that you're doing. And I'm a physician, so I know that we're all trying to get on the bandwagon of being proactive and treating people on the front end rather than waiting until they get sick. We're trying to do some of that at the state level too. But behavior change is really hard, and I'd be very interested in whether you feel like you're actually getting your employees engaged enough to move the needle, and whether you're seeing the results in your biometrics, or if you have been doing this long enough to see any results.
Sure, I'll start on that one. So we do measure biometrics every 2 years. So when our data for 14 is not as robust as 16, so we're going to do biometrics February through April in 18. So we've already built in the comparison tool to say where were we in 16, where are we in 18. And then from a risk score perspective, which is how Mohawk, even though risk score doesn't seem to, the whole population health thing seems to be on a downswing, we really think that's the ticket for us. So when we look at population risk score, from a retrospective and prospective, we can tell that people who are using our clinics are marginally better than those people that aren't using them in the same area. So that's based on the last, I think, 18 months. So we're going to continue to drive that, anticipating that we can not only continue to make that inroad, but that as we deploy our care teams and offer that same kind of support, we're going to be able to do it in other pockets in the country, from our perspective.
I know for us, the one thing I'll tell you, and let me give you a good example. We have an employee, her name is Sarah. She has diabetes and she's obese. So just hearing that, your first reaction is, well, you need to eat better, you need to exercise. Well, what if I told you she's working 2 jobs and that her neighbors are having to keep her 3 children because she's a single parent? Then you start looking at this a little different. Then you've got to start looking at well-being as a whole. And that's something we're trying to do at Southwire to better understand what are the underlying reasons for behaviors and what's happening to our community, to our members, and to our employees. And that is a can of worms. That is everything from education to socioeconomic. We have a pension plan, people don't contribute, nobody's saving, all those horror stories. But you know what? Yeah, you have to start somewhere, and nobody else is going to be able to do it.
So I think that's another good point. So we just brought in behavioral health into our on-site clinics. So we've always had the traditional EAP, but people are comfortable going into the clinics, and so we're banking on that access right there. You know, the coach that you trust, the mid-level that you trust can walk you down the hall and say, here, I want you to meet Barbara, she's not so scary, right? And so maybe you guys could just visit for a minute and then figure out how to evolve that. And I think we also have, Mohawk was never really a fan of promoting the success stories because it was too anecdotal, right? We're a manufacturing company, so you measure everything. But we've had so many of these success stories where they had their aha moment as a patient that they talk about it, right? They share it over their lunchroom break. The whole notion of biometrics, certainly we were probably no different. Everybody was like, ugh, really? You don't need to get anything about me. I don't want you to know. But over now our 4th episode coming up, people are like, okay, we're ready. I need to know what my numbers are. So it really has helped, and we will continue to measure that. Sorry.
And we've seen the same thing with our biometrics. We've seen a decrease in chronic disease. And I think a lot of it has to do with our health advocate that meets with the employees and also helps them navigate the health system. In addition to that, TLC Benefit Solutions is our TPA, and there are a lot of our employees that use the folks over there as a resource as well as far as navigating. Many of them bring their bills over and sit down with one of the ladies there, and they go through and she explains what the EOB is and what you're supposed to pay, don't pay any more than this. And a lot of times they'll call if they have to have an MRI, and they'll say, okay, I have to have an MRI. Where's the least expensive place to go get the MRI?
Yep.
Where do I need to go? Because we've done some direct contracting for imaging.
I wish I had a wonderful story to tell you. Our biometrics are so much better, but they're not. But what I'll tell you is that not getting worse is improvement.
Yeah.
And my CEO hates it when I said that before.
But it's
because
true.
it's all like, you got to get better, and they're competitive, and we got to be the best.
Keeping well people well.
Yes,
can have a huge
and
impact.
as we age, doing nothing gets you behind, as the gentleman said earlier. Doing nothing is not optional. So anyway.
So
Back here.
having a great insurance plan is great and all that stuff, but what are practical things that are you doing to communicate that to your employees? Because we have different generations. We have baby boomers, we have Gen Xers, millennials. What are you doing to communicate that? Because that's key. You might have the best plan out there,
Right.
but if people don't know.
Could be a secret.
Kim, you had the slide actually that showed yours by generation, right? Your
Right.
employee staff,
So we probably do what you guys do too, is we communicate in every channel we can get, which was not historically our MO, right? We sent you something at home. Now we text you, we call you, we use videos. Mohawk is an intranet site. We're very big fans of postcards because it forces us to be concise in our message, and we make them really bright and colorful. So maybe on the way to the trash can, you might, give it a gander. So we communicate in all those different methods, and we communicate to spouses.
And it's constant communication. Constant.
And I think the thing to remember is people will not take time in their limited range of capacity until they need to know it.
That's right.
You're not going to get a conversation. I can come and teach you everything I know about healthcare, and it will mean nothing. Because if nothing ever happens in those things, it won't be relevant. But what I will tell you is that we're approaching it maybe from a different standpoint. We're looking at megatrends, and I don't know how much you guys probably are better at it than I am as far as the retirement rate and the replacement workforce that we're dealing with. And being a manufacturer, nobody wants to be in manufacturing. Parents aren't getting their children to do that. So what we're having to do is there's going to be a big gap of workers and our ability to do what we're doing. There's also a change in relationship to a lot of our wire and cable products probably won't be here in 10 years. So we got to hire a workforce and train them to be something more than who they are. So we look at something called employee experience, and that's the way we're looking at it. From the moment you hear about us till the moment you retire, how do we interact with you? And again, it's that well-being. And our hope is that it's going to retain you. It's going to help us get the good folks in the right place. You don't always make wire and cable in the hot spots of Hallsville, Kentucky, and Flora, Illinois. I doubt some of you have ever been there, but you can't just look at it in an isolation. You can't just communicate to someone. It's got to be surround sound. You got to do it all. Talking about your career, whenever you're talking to me about anything, I can throw in something that relates to that. So,
Yeah, any other questions there? Yes, sir.
Yeah, over here on the side. I've had the fortune of visiting all three of your facilities and have found them very impressive. I appreciate what you're doing with physical health. Does this transfer over to mental health as well?
Does it transfer? I'm sorry.
Are you incorporating mental health? What we're noticing in Georgia, we're having an issue with.
Right, as are we, because when we look at our chronic conditions de-identified, right, like 98% of them are also depressed.
yes.
Right, so no wonder if you have diabetes, COPD, you have a BMI of 40, yeah, you're not feeling very well. So, as I said, we've always had the traditional EAP, but we've recognized in the last 2 years that's not enough. So we're bringing in, they've actually started at our on-site clinic, and so we want to use telehealth. Mohawk has bought 10 kiosks with a telehealth partner. We're deploying them in different locations, and so we want to be able to provide not only on-site, because once we can get some stickiness, it really does grow, and then from the telehealth perspective, just provides broader access. And if we can connect the person in Muskogee with our mental health provider, potentially either in Oklahoma, or get them licensed to be in Georgia so they can multi-state take care of these people, then that's what we want to see happen.
So, one of we kind of track the trends, or, what's the top discussions that we're having among this group now. And one of those is behavioral health. How it just seems like it's kind of evaporated, especially from the rural communities. I saw a slide the other day that showed the number of psychiatrists in the state of Georgia, and it was like Atlanta, and maybe a few others. And there's just, complete desert everywhere else. And so how do we help these people? We've done another pilot in Coffee County working with the kind of famous Institute for Healthcare Improvement out of Cambridge, and working with obese women. The 4 employers involved there, 68% of the female workforce was clinically obese, a BMI of over 30. And guess what? Surprise, surprise, most of them had 1, 2, 3 other chronic conditions. And the first pilot group we put through, 5 of the people were nurses and health clinicians. And so, it dawned on us, my gosh, these people know what to do, but through different social determinants, behavioral issues, they needed help. They couldn't get it done. And it turned out it wasn't, the physical therapist there making them do jumping jacks that helped. It was just being there listening to the folks. And so, that's something that we really need to think about as policymakers. We've got a group of people that are not only physically ill, but many of them have, mental issues that we need help with. Did I see another? Yes, sir.
An excellent panel. The state of Georgia has consistently now, over the last, since I've been following it, is ranked in the lowest quintile by the United Health Foundation in terms of health outcomes. And what we see here are 3 excellent examples of leading employers that have done a really good job of managing outcomes and costs in combination, measuring and managing. You've done, to varying degrees, you've done this. The question I'd like to ask is, have you thought about ways of projecting your success stories, not only just to other employers, but to other stakeholders in the system with respect to the fact that you haven't improved your role, how you were performing your role as purchasers? And there are lessons to be learned from that are transferable or that are meaningful to other stakeholder groups in the system, like, for example, providers. So the question I'm asking you is, given particularly your interest in the health of the larger community, have you thought about how you can project your success stories more broadly?
I think one of the key things that we have done the last couple of years as we have engaged with the Georgia Hospital Association, Now, frankly, I can take you to communities in Georgia where the major employer in the community will not go to that local hospital, won't have anything to do with them, won't talk to the board, won't talk to anybody, okay? I can also take you to communities in Georgia where the employers are very, very involved with the local healthcare system. They appreciate it, they're part of it, they help make those decisions. We've got a great example with the Savannah Business Group in Savannah, Georgia. That's a group of a business coalition, and they're part of our group, but they have been very engaged with the local healthcare system, and it has improved care and reduced costs for everybody there in the Chatham County area. So there are examples. Too often, though, employers are put in a negotiating position. They go to the local hospital when it's time to talk to them about the contracts and stuff. And we've got to create opportunities where they develop a true relationship. Some of the stuff that's being done with Healthcare Georgia Foundation, trying to put together community activities where everybody is coming together to look at the health of the community. And we're encouraging employers to take part in that.
And you really can't, there isn't one stakeholder to blame that can improve it. We all have to do it. And I would give anything to find a way to partner with the healthcare system so that we can transform it. The clinic that we have is operating in a vacuum. My doctors get paid for outcomes, not volume. But they've got 65% penetration rate. So we have people come in there. They're good providers. But when I sit down with the hospital system, they're operating in a different world. They get paid when people are not well. They get paid for bringing in services that may or may not be increasing the health of the community because it's generating revenue. So I get it. I worked in the healthcare system many, many years ago, not as a clinician, but it's so hard because we don't understand them and they're not understanding us. And sometimes they do, and it's just not feasible economically to do something.
So we've come to the end of our time, and we'll be around hopefully during lunch and stuff, and you can ask further questions. And anybody who's interested in joining our group, just let me know. We'd love to have you involved in the discussion. But I want to leave you a little challenge this morning, okay? What's that commercial? I forgot the company, but yes, you can. By gosh, yes, you can. That's the attitude that these folks are having, and they're going out and they're making a difference. And don't forget, a difference in one person's life that's on the employee line, it really is a generational change that you're making. Some of the folks that we've dealt with in a pilot in Coffee County again, they said, you know what, from what we've learned, we're not bringing that stuff into our home anymore. And so that woman is immediately having an impact on her husband, her kids, and her grandkids. So, never underestimate just the change that we can have with one person, the impact. So yes, we can make a difference. And as state policy leaders, why not bang your gavel, okay? And say, by gosh, Georgia is going to be a healthy state. We're gonna just put that out there. We're going to improve the health of the state of Georgia. We're going to have a big, hairy, audacious goal to make that happen. And then I think we would all be surprised how everybody, from their own perspective, will fall in line and try to help with that. But I don't sense that. We're a state that's open. We're an economic development state. We're open for business. Well, guess what? Healthcare is going to kill business, and it's going to stop recruitment. It's going to stop expansion. So I would hope as a state leader that you pick up the mantle of creating a healthy Georgia. Thank you for your time.
Thank you all. Let me echo Don. I think this is inspiring because, again, in difficult circumstances, they show that this can be done. And I remember Sonny Perdue, when he was governor, he put together an employer group, and I think Barbara was on that group. He was doing it, yes, to make us a healthier state, but his purpose was an economic competitiveness issue. Exactly what he said. He said in many parts of our state, healthcare costs are among the highest in the country. You're not going to attract businesses to that part of the state if that continues to be the case, and it still is. So let me summarize a little bit some themes that we're going to talk about in our next panel. They invested in primary care. This is the best return on investment that you can make. They have flexibility. There's a saying in rural healthcare, if you've seen one community, you've seen one community. They're all doing a little bit different things to fit their community. They need the flexibility to do that. And data. We've got to have access to our data and analyze it. We lead the nation in health IT. We can do that. We can be the leader in the country. And so we're going to talk about that in the next panel. We're going to take a 5-minute break, and we'll be back in a few minutes.